All right, so we have a fantastic session planned for you all. Joining me immediately following this is my good colleague, Dr. Marco Arac. He was instrumental in helping us get accredited for this summit, but more importantly, he welcomed a new baby girl last week. Mom and baby are doing well, and she was kind enough to allow him to leave the house for a couple hours to be with us today. So please give him your undivided attention. Dr. Arac is currently a lecturer at Tamarity Faculty of Medicine, U of T. He also brings experience from previous roles at Sickle, Queen's University, and the Serbian Society of Emergency Medicine, and he's a current practice emergency physician at Humber River. So without further ado, Dr. Marco Arac.
I'll be quick. Hello. So I'm here to introduce a colleague of mine. This next talk is quite an interesting one, and hopefully will be transformational what we do at our hospital, and hopefully for you guys at your hospital. So Dr. Rivlin is a colleague of mine. He's a mentor of mine. He's actually the one who hired me at Humber, so that's why I'm here. He's the founder and CEO of the Rivlin Medical Group, which focuses on chronic pain and multimodal management of pain outside of the hospital setting. He's also the chief of the emergency department at Humber River, where he's overseen the last year, 2 years, 3 years, our transformation of our sickle cell care to be in line with Ontario Health and the other hospitals too. So Dr. Rivlin, we'll get you to give us your talk. Thank you.
I'm bringing up my phone only because I want to put the timer on so I could try to stay on time. That's why I have my phone here. Well, thank you very much, and thank you for that introduction. And Marco is definitely one of the best docs that I hired over the 10 years that I was at Trillium, so I'm very happy. Anyway, thank you for having me here. I thought we would talk about the innovation of pain management, and Penthrox is not used for sickle cell management right now. I want to make that very clear. It's methoxyflurane. We'll talk more about it. And the reason being is because we're only initiating the approval process of methoxyflurane through Health Canada. So as we're sort of looking at this as a viable potential option for pain care, we thought that it would be a very interesting medication to talk about. Right now, methoxyflurane is used for the management of trauma pain, and it's been shown to be very effective, and I'll talk to you about that. And also it's being used in procedural related pain. A lot of cancer procedures that are done that are painful, patients are given methoxyflurane in order to help manage their own pain response. So just a disclaimer, I didn't receive payment for this presentation. I have full editorial control. The slides were put together initially by actually it wasn't Knight Pharmaceuticals at the time, now they're Knight Pharmaceuticals, but they're the scientists at Knight Pharmaceuticals, and they're not intended for any commercial use of the product. And I have no conflict of interest to disclose. So let's just talk about pain management challenges. Access to pain is a human right. It's accepted by the United Nations and regional human rights bodies. And analgesia at the site of an accident or at the site of any location of pain is a human right. Unfortunately, there's an undertreatment of pain, and this is a problem. And this is a problem that exists in all aspects of pain, including sickle cell disease crises management. And there's no single standard of care that currently exists for the management of pain. So, for example, if you're having a heart attack, we talked about people with an MI, we have a standard of care. But if you're having pain, depending on where you are in the world, you're managed, unfortunately, differently. So the pain continuum. As an emerge doc, we look at what happens outside of the hospital, and then we kind of go through this pain continuum of what happens within the doors of the hospital and then outside. So outside of the hospital, a lot of patients are treated either non-pharmacologically, like here's an ice pack for your broken bone, or they're given Tylenol or Advil. And only now we're starting to see the use of opiates by paramedics, but that's not universal at this point in time. By the time you get into the hospital, then systemic opiates are being used, and then of course we try to wean patients down by the time we're sending them out the doors. So when we talk about procedural pain management, across the top, you'll see that there are different medications. So you have Tylenol, acetaminophen, non-steroidal anti-inflammatory, so that's like Advil. There are opiate medications. Then you get into stuff like nitrous oxide, which is laughing gas. You get that at your dentist's office often. Then we get into intravenous opiates, which is the standard that we're currently using when we have somebody coming in a sickle cell crisis. And then we get into much more complex medications which have higher risk, ketamine intravenously, propofol, and then midazolam somehow got lopped in there. That's more of like like Valium. That's more of a sedation type of a medication. But ketamine and propofol are dissociative medications. What they do is they help people fall asleep effectively, and that helps manage their pain, which allows us to do procedures. So penthrox, or methoxyflurane, is, as you can see there highlighted, it really fits into that mild, moderate, or possibly even moderate to severe area of pain control. And that's where we looked at it and said, well, you know, if there's a quality assurance initiative in the province to help manage sickle cell crisis pain quickly, what about penthrox? So, you know, we want to talk a little bit more, I want to talk to you a little bit more about levels of sedation, just so that you can understand where sort of penthrox fits in, because at the same time, we don't want to sedate patients so heavily that methoxyflurane kind of knocks them out. And so it wouldn't give minimal sedation, but it would kind of fit between minimal and moderate sedation, meaning that patients who receive it get a little bit sleepy. But patients who receive morphine or hydromorphone also, so that's what we're sort of shooting for. Then, of course, we get into deep sedation and general anesthesia, and methoxyflurane in this format doesn't do that, but there is a different format, which I'll talk to you in the upcoming slides, where you'll hear more about what methoxyflurane does. So just looking at what is an ideal analgesic. Well, effective analgesia, so you got to get pain relief from it. Fast onset and fast offset, meaning I'm giving it to you, you're in pain now, you want it to work right away. You want it to last long enough. You want it to be easy to administer, easy to titrate the effect, meaning that if you're using it and you're finding, I'm good right now, I don't need quite this much pain medicine, then you can back it off on your own, or increase it for that matter. It needs a very good safety profile. Non-dissociative means that it doesn't knock you out completely and that it doesn't impair your vital signs, so you don't want to be taking it and stop your breathing. Ideally, if it can be non-opioid in this particular situation, that might be good. Non-addictive, definitely we want that. It needs to be portable, and any adverse conditions, this is more in the world of trauma, where if you're using it in a helicopter as you're transferring a trauma patient, or if you're using it up on a ski hill, then you want that medication to actually be both active and to be available. So speaking of ski hills, I was skiing one day and with my partner, and I see this. So you may not see it from that perspective, but this is a guy who was skiing. So this is Europe, right? And in Europe, a lot of people who ski tend to have a few cocktails. And so this poor fellow, as he was skiing to the chalet, fell and dislocated his left shoulder. He allowed us to take some pictures. And so he's holding in his right hand, because it's the left one that's dislocated, the medication that I'm going to be talking to you about, which is methoxyflurane, puffing on it while the ski, paramedics are bringing him down to base. Or he could have taken a helicopter for $10,000. So it's a tough call. So methoxyflurane is used in various parts of the world already, and it really started in Australia. It's been used in Australia for over 40 years. But also there's a lot of use in New Zealand. It's used by paramedics in hospitals, and in Australia, the reason it started being used by paramedics is because it's hard to actually access a hospital within a timely period of time. So they say, here's your methoxyflurane, hop in the back, we're taking you to the hospital, take about an hour. But it's not just, we see it in England, we see it all throughout Europe, and it's being used throughout the world for the management of severe trauma-related pain. Now, the interesting thing is, and don't quote me on this per se, but I'm hearing rumors that it is being used for non-trauma-related and non-procedure-related pain, so it could qualify, for example, for sickle cell, but not in Canada or North America at this time. So at Humber, we have initiated this process with Health Canada, and we're the first, actually in the world, that has sort of taken this on, and I'm very happy about that, where I'm hoping that we can start this from a research perspective initially, just to make sure that it's actually doing what we want it to do, and then kind of take it and make it a standard of care. So just a couple of types of accidents that methoxyflurane has been used for, just so that I wanted you to get a sense of the kind of pain that people have and the kind of pain relief that it provides. So I'm not going to go through this list extensively, but if you look at the injuries, there's the fellow who's 76 years old who had rib fractures and a pneumothorax. His initial visual analog score for pain is 6 out of 10. And then within a couple of minutes of the methoxyflurane administration at the 5-minute mark, his pain went down to 1. The one who's really been having a bad day is the fellow who had, there's an attack by a cow. I didn't actually know cows attack people, but the poor fellow had a severe amount of pain, 9 out of 10, and it dropped down to about a 1 as well. So, when we look at that column, the pain score at the leftmost column, baseline pain score, and then the 1-minute pain score, and then the farthest right column, which is the pain score at the 5-minute, you can see that there's a sizable reduction in pain consistently. So it works, which is helpful to know. What is methoxyflurane? So methoxyflurane, before 1972, it's a fluorinated anesthetic agent. So what that means is that when you're having your appendix out, you're given methoxyflurane, you're knocked out, you're given methoxyflurane. It's the gas that the anesthetists give, and it provides you pain relief. You're under general anesthesia for a prolonged period of time. How it works, the short answer is no one exactly knows, but the longer answer is that sometimes it's believed that it can disrupt the connections between nerve cells, or it potentiates centers in the brain called the GABA centers, where it actually helps facilitate pain relief. There's also membrane fluidity, which means that nerve cells that are next to one another, they communicate that way, so it actually gets in there and it prevents that temporarily, and it prevents connection of pain in there. It's a clear, colorless, volatile liquid. It has a characteristic fruity smell. To me, it smells more like a marker, like a magic marker. At high doses, it's an anesthetic, but at lower doses, it's an analgesic. So the anesthetic is what we were talking about before, which is if you're having a major operation, then methoxyflurane is used as an anesthetic. The reason that it stopped being used as an anesthetic was because on very long procedures, up until 1972, we're talking 3-4 hour long procedures, it started to actually cause some organ damage. So it fell out of vogue, and people said, there are substitutes for this that are better, and we're not going to use methoxyflurane. But at low doses, in the way that it's been used as an analgesic, it hasn't caused that kind of organ damage at all. So it's a much more effective tool. And you may ask, well, why use methoxyflurane if it has a history of had this bad reputation around causing organ damage? And I'll explain that in one of the next slides. Actually, this slide. So people who inhale methoxyflurane need a very low dose of it in order to have pain relief. Whereas if you look at its brother-sister sort of medications, which is halothane, isoflurane, sevoflurane, you need a lot more of it in your lungs in order to get the same kind of pain relief. So where we get into a problem is if we were to give one group of people methoxyflurane in a little pipette, and then we would give another group of people halothane and tell them all to sort of puff away at it, the methoxyflurane people will have relief in about 10 puffs, whereas the halothane people will not. They'll be puffing away and saying, now can you please give me something actually that works? Whereas in an operating room setting, they provide pain relief in a similar way. So because people have a tube in their throat and they're on a breathing machine, so it makes a lot more sense to go with the safer medication that's being used for a prolonged period of time. All that to say that what we found in the implementation of methoxyfluorine for trauma care and I even use it in the pain clinic, is that it provides fantastic relief, and we've had actually we've had no side effects with it at all, and certainly no major kidney or organ damage. Okay, so how does it work? So you can see there that it's a little green pipette with a little tube on top. That tube has charcoal in it. And then there's a little bottle next to it as well. And so that's how it comes. It comes in a box. And what we do, I'll flip to the next slide, which is a cross-section of this. So this kind of helps you see it a little bit better. And what we do is we take that little tube, the little glass vial next to it, right there, and we pour it inside. And what you see inside of that green pipette is a wick that absorbs it. And then the patient's mouth goes on the far right side, where the side where the Canadian flag is. And so the patient is instructed to breathe in and out. Now, patient direction in this is extremely important. And that poor fellow on the ski hill, he needed a little bit of instruction, which he wasn't getting around using it properly. So patients tend to use it like one would see, I mean, I don't vape, but like you would see a vape, where you kind of breathe in and then you kind of talk to your buddies for a little while. That's not how it works. So we instruct patients to put it to their mouth, and we tell them ahead of time, breathe in and breathe out through the pipette. It kind of stings a little bit initially, so it kind of hits your lungs a bit. And so a lot of them describe that. And we tell them to take 10 practice breaths. And we instruct them specifically, breathe in and breathe out through the pipette otherwise. And it's not hard, like there's no resistance. And so after about 10 breaths, they feel some pain relief, and they feel an initial change in their pain. And then we tell them to use it for their breathing to the extent that they want pain relief. So basically we'll say breathe in and out as much as you want. If you're not getting enough pain relief, there's a little diluter hole. You can see that on the top of the charcoal filter. And if they plug that, that increases the concentration of what they administer for themselves by 50%. So it's a huge increase. So where is it used? Armed Forces. It's used all throughout Canada in the remote areas, and of course all of these hospitals. And this isn't a comprehensive list. I just wanted people to know that this is what is currently the distribution of this medication. In our pain clinic, we've been administering it to patients who are undergoing nerve block procedures, and we give it to them. We train them on how to use it, and then once they start, after about 3 to 5 minutes, then we can start the procedure. And we have a couple of publications that we've presented showing that there's been significant improvements in pain. What are the contraindications? So if there's hemodynamic instability, meaning their blood pressure is too low, their heart rate is off, if there's a pronounced respiratory impairment, so they're not breathing on their own, or if they can't follow instructions. Malignant hyperthermia is a form of adverse response to anesthetic medications. So if they have that or that in their family, then we don't give that to them. Clinically significant kidney problems. Not dialysis, but pre-dialysis, because if they're already on dialysis, then the kidneys are already impaired. So it's not, you can't harm something that doesn't work. Clinically significant liver disease, and then if the patient can't follow instructions. So if they're too unresponsive and they can't use it, then they can't receive this medication. And this slide is just to really say that it has minimal effect on blood pressure, heart rate, and respiratory rate. There are some drug interactions. So methoxyfluorine is metabolized by an enzyme in the liver called cytochrome P450. And the interactions are, one is, of course, if the patient is already using a medication that is metabolized by this enzyme, cytochrome P450, then it's going to make more of these metabolites that are potentially a bit toxic. so we have to be careful with that. If the patient is receiving a central nervous system depressant, so something that makes them sleepy or groggy, then we once again have to be careful, but it doesn't mean it's a contraindication, because there's plenty of patients who we see in the emergency department, they come in with a dislocated shoulder, we give them some morphine, and now we give them methoxyflurane, and we go ahead and we put their shoulder back into place, we reduce it. And then if the patients are using a concomitant medication or an antibiotic that can cause kidney damage, then we have to be quite careful around giving them this medication as well. But really, there's been very few drug reactions over 40 years. So in Canada, children are not allowed to receive it, but this is from Australia. These studies from Australia basically show that children and pregnant women have had a safe response to it, although it hasn't been indicated it hasn't been contraindicated in pregnant women. And then with lactation as well. So patients who are breastfeeding, we're just cautious about them receiving it. But on the most part, you can see that the numbers are very low when you look at occupational exposure, intentional misuse, so dependence. Kidney impairment, 8 cases out of millions, right? Malignant hyperthermia, 1 case was reported, and then kidney impairment in these millions of cases, there are 4 reported cases of kidney impairment associated with oxyflurane, so it's very low. Then, of course, the question that I often get is, when can this patient go home after they've received this medication? And the studies show that after 15 minutes of stopping the medication, it's almost completely washed out. After 30 minutes, you're back to your baseline, you can get in your car, and you can safely drive home. Yeah, it's really impressive at how quickly it works. And this is based on cognitive testing by I guess, people who do, like psychologists who do cognitive testing, who basically administer the medication and then say, please do this complex task, and then we can see those changes take place. As far as occupational exposure, the first thing that I thought about is, am I getting some of this? Because you can smell it in the air as the patient is using it. So the short answer is no. And we went ahead and we did a study, a literature review on the occupational risk, because we wanted to assert for ourselves that this exposure is not at risk to us. And you can smell it at 0.13 to 0.19 parts per million. So it's a really small amount. That's when you can smell it. But the occupational exposure level is 15 parts per million, so 100 times more. So you really need to get a lot of that. You literally need to take the pipette from the patient and start puffing it yourself in order to get like the occupational exposure. So it's safe. Dosage and method of administration. So each bottle is 3 milliliters of that fluid, and you pour it in, and then you hand it to the patient, and if the patient is breathing with it continuously, it will last about an hour. And then if you need another hour of pain relief, then you can take that second bottle, you can pour it in again, and you can give them 2 of those, so 6 milliliters in total. But then once you get into, and then that's it. That's all you can safely give at this point, because then we worry about all of those harmful side effects that I talked to you about. And then for patients who receive repeated procedures, so we're talking about either the patients in our pain clinic or patients who are having recurrent cancer-related procedures like bone marrow biopsies, for example, where they're coming in every couple of months, then you can administer 5 bottles over a 3-month period safely. Now, interesting, and I get this, so this is a little bit off the record, but I get a lot of questions from people asking me, well, how long does it last? So I've noticed a 2-wave effect, and this, when I say off the record, it's because the studies haven't actually been done on this yet with our pain patients, where they'll say, I've received the methoxyflurane, my pain has been great during the time of the procedure. And then they'll come back the following week or 2 and we do a follow-up or we do a phone follow-up, and they'll say, the pain relief from this compared to when I didn't receive it is fantastic for an additional 3 days. So what's interesting here is that we're starting to see a prolonged effect from possibly or likely the metabolites from this. So the half-life is only about 33 hours. It means it stays in your system for about 33 hours without you being feeling or without one feeling like it's there, but it provides pain relief for up to 3 days. So this is kind of going to be very interesting to explore further, and this is going to be one of the studies that we're going to do down the road. So from the sickle cell perspective, one wonders if you're giving it to them, to a patient who's in sickle cell crisis, to bridge that point in time from acute presentation of sickle crisis to when we're able to give them something else like hydromorphone, which lasts a few hours, not just an hour. Does it actually allow patients to have a decreased baseline of pain relief, so lower their overall pain for the next 24 to 36 hours? So that, yes, they'll still need something more. This won't be enough, but maybe they won't need quite as high a dose. Okay, storage and handling. So it has a 3-year shelf life. It can be used in high altitudes, ski resorts, and in extreme conditions. So when we talk about extreme conditions, it could be stored between 5 and 30 degrees, but you can use it at negative 35 degrees, or up to 30 degrees Celsius in super hot conditions. And of course, then the disposal of it is really simple. It comes with its own little disposable bag. You put it into the Ziploc and you throw it out into like regular garbage, and that's that. Of course, I'm biased, so of course I have to talk to you about emergency medicine specifically. Why wouldn't I? So in the global world of emergency medicine, it's great for multimodal pain relief. What I really like about it is that it's self-administered, and we've shown over and over again that patients who self-administer their pain control, so self-controlled analgesia, they have much better pain relief at much lower doses than patients who are administered pain relief by the provider. Listen, I mean, take what you can get at the time when you're coming in crisis, but ultimately, I think it's a great tool to have. Procedural sedation resources are saved. So this doesn't apply so much to sickle cell, but for people who need to be sedated, broken bones, that sort of thing, we don't have to do procedural sedation. We can just use the Penthrox often in order to manage their pain. It's currently, and this is just to bring people's attention to the fact that it's not just used in the emergency department or by the Army. It's used for endometrial biopsies, IUD placements, colposcopy, diagnostic hysteroscopy. It's used in minor operative gynecological procedures, Bartholin's glands, cyst drainage. We use it in the emerge very often. It's been shown to be very effective in fracture reduction, where we reset the bones. For hardware removal, so people who come in with a screw and a pin and I hope I don't gross anyone out, but they have like a pin and screw in their ankle and they want the screw out, we can just give them the Penthrox, and we don't do it in the emerge, the surgeons do it. So, and then joint manipulation as well, so shoulder reductions. In fact, there's a study which showed that of the patients who came in with dislocated shoulders, 100% of them had successful results, actually. Did I share that one with us in the emerge? No? Yeah, I should. Had successful results with methoxyflurane, yeah. So speaking of studies, so this is a study that was done in England, and it was a randomized, multi-center, double-blind, placebo-controlled trial. So some people got Penthrox and some people did not. And I'll explain, it sounds cruel, but I'll explain how that worked in an ethical way. And it was Penthrox for the treatment of acute pain and trauma. So what were the traumas that they had? I'll go through this. So a lot of the traumas were things like burns, shoulder dislocations, ankle fractures. We're not talking about multi-system trauma where they slammed the car into a tree and got dragged out by the jaws of life. And so there were two arms to this study. On one hand, we had the people who received methoxyflurane, and then on the other arm, we had people who received a green pipette as well, but it had a placebo in it, and it was designed to look and smell exactly like the methoxyflurane. The way that this passed ethics is because there was a rescue medication that was used. So both arms had the option of having a rescue medication. So if you say, I'm in a lot of pain, they receive either a non-steroidal anti-inflammatory and or they can receive fentanyl. for their, like intravenous fentanyl for their pain management. And then their pain intensity score was monitored and documented at 5, 10, 15, 20, and 30 minutes. And from the start of the initiation, and then there was a follow-up as well. So the visual analog score here is done in millimeters. So basically 0 is no pain, and 100 so think of a ruler, and 100 millimeters is, or 10 centimeters for that matter, is the most pain that you've ever had. So this is how patients presented. So this slide just tells us this is how they came in. So a lot of patients came in with a pain score of around 64, or 6.5 out of 10. And what obviously, and the kinds of injuries that they had, or there we go, I was talking about them. So burns, contusions, dislocations, fractures, foreign bodies, lacerations, other kinds of wounds. And then once they received the methoxyflurane, we saw an improvement in pain at the 15-minute mark. So at 15 minutes, we see maximal improvement, but improvement starts as early as 5 minutes. And we saw that there's a 3.4% reduction in pain. So if you're coming in with pain that's like an 8 out of 10, it drops to a 4.5 out of 10 in the first, in 15 minutes. Whereas the placebo group, their pain dropped just by 1.5 points, so not really significantly. And you kind of ask yourself, well, how did the placebo part of it relieve your pain? But there's a lot, you calm the anxiety, you're now in a hospital, you feel a little bit better, you have healthcare providers that provide you ice and conversation and stuff, and so that would explain that level of pain relief. So the magic number is 15 minutes. At the 15-minute mark, you can see with the red circle there that there's substantial pain relief. The darker green line is the line that received the methoxyflurane, and the lighter green line is the line that received just the placebo. The other thing that's interesting about this slide is if you look at the 5-minute mark, you can see that even at 5 minutes, patients already have 2.5 points of pain reduction just from that alone, which is fantastic. So think about it from the sickle cell perspective. Somebody comes in with a sickle cell crisis-induced pain. You prepare the Penthrox, you hand it to them, and while you're going, and this is to the nurses in the room, while you're going to initiate that protocol where you're kind of preparing the IV, starting the IV, getting the hydromorphone, all of that stuff, the patient is already experiencing pain relief. So the conclusions were that there is significant improvement in pain relief, there's rapid onset, first pain relief was at the 4-minute mark, and the patients in the Penthrox arm, they received less rescue medication, practically no rescue medication. And then, of course, the analgesia with the Penthrox was durable. It lasted almost an hour, and we know that as we administer it, it can continue to last another hour if we need to buy more time. So I like to end with a bit of a good news story. So I'll talk about, this is a patient who I saw in the emergency department. It wasn't sickle cell, but it was a story that kind of made me think, this is really unfortunate. So this unfortunate 74-year-old woman was leaving rehab after she was in rehab for 8 weeks. She had a left knee replacement. And as she was walking out, she had a mechanical fall and now broke her ankle. Can you imagine? Like, that's just awful. So isolated left ankle injury, pain was severe, 8 out of 10. She has a history of osteoporosis, so thinning of the bones, coronary artery disease, type 2 diabetes, and patient announced to me that she can't have general anesthetic. She was 74, so she has not had malignant hyperthermia, which was the very first thought that came to mind, but she said her doctors told her that she can't have general anesthetic, so what are we going to do? We can't give her sedation. And of course, as usual, the emergency department was super busy, and I couldn't get a respiratory therapist. I couldn't get a nurse, a second nurse to help me. We had to do it, and I couldn't get a monitored bed. So we had to treat her pain right there where she was, which was in subacute, which is our sort of sicker patient area. For those who could look at x-rays, what you'll see here is you'll see on that first view that that bone should be aligned. It shouldn't be sort of off to the side, that long bone. So you can see that there's a pretty massive fracture there. And we call that a trimalleolar fracture. So all 3 bones in the ankle are broken. and we needed to set it. So she did get dilaudid, 1 milligram, and then I came back into the room, and she goes, "Doc, are you actually going to give me something for pain relief?" So I said, "Well, the dilaudid should have worked. No, it just made me sleepy." Okay. The respiratory therapist was not available. The nurse needed a bit of instruction very quickly, picked it up like that, around what needs to be done with Penthrox, due to excellent nursing education at Humber. And we prepare. And while I was preparing all of the plaster and the splinting, the nurse started with the patient on the little pipette, and we completed the close reduction in less than 10 minutes. She did feel a little bit of pain, but practically insignificant. I did follow up and say, how did it go? And then the maximum pain level during the procedure that she said she experienced was a 4 out of 10, and she was never asleep during the entire procedure. And then you can see here, it's the casted view. The splint held the bones in position, and then she went off to our orthopedic surgery specialist with significant pain relief and bones in place. And that is it. It's been a pleasure.
Thank you, Dr. Rivlin. Any questions? So, right over there. I have to come there. Sorry.
Hi, great talk. My name is Chris Travers. I'm actually a clinical geneticist. And so my interest from this, I teach on pharmacogenomics. And I know in most safety and efficacy studies for almost all drugs are done on white middle-aged men. And so if you're not white, not middle-aged, and you're not a man, the data sometimes can be a little bit iffy. But I also know that for opioids, in people of African ancestry, 35 to 50% of them actually have genetic variants that mean they aren't getting enough, or they're getting too much that puts them at risk for adverse side effects that can be serious. And there are guidelines from the CPIC in the US, and there's Dutch guidelines. Canada's catching up, but it's missing from a lot of drug trials. And I while you were talking, I was looking up the drug you were talking about, focused on, and there is variation. There's 3 different pathways it goes through, and I wonder sometimes in treating sickle cell whether the drugs are actually good. It's just that we're not prescribing them in the right way, tailored to the community, and some of them are being tossed aside that could be useful, and then other ones that are tossed aside because they're actually causing side effects could be adjusted as well. So,
I'm glad you brought that up. I think that's at the top of mind for me when we look at the implementation of methoxyfluorine for sickle cell crisis. The big question that I ask right off the bat is, physiologically, can we be certain that it doesn't cause harm? Because currently it's used for a type of pain called nociceptive pain. And what happens in those cases is that the nerve fibers are being stimulated by painful stimuli, some kind of a manipulation. Nerves are being touched that are not supposed to be touched, right? Like broken fragments of bone, for example. But in sickle cell, it's more of a vaso-occlusive crisis, and what happens there is there's actually ischemia. So it's a slightly different mechanism. And then the question that I have is, for our researchers, one is, of course, does it potentially make the ischemia potentially worse? Could that happen? So that definitely worries me. And then the second question is, will it provide as good of pain relief as it does with this mechanical pain, or will it provide better pain relief potentially? Because so we have work to do for sure, and I'm glad you brought to the forefront of this the actual genetic variations that are also extremely important. So there's a lot of opportunity for us to explore with this, and currently we're looking at it from the drug trial perspective, and we're going to monitor those patients who receive it very closely. But having said that, it's got a very safe patient profile, and so right now it doesn't appear to to have a risk in any patient population at the moment. Yeah.
Thank you. Another question right here.
Thank you very much for the fascinating presentation. I've got a question regarding diet. And you mentioned earlier during your presentation about cytochrome P450. I won't get too medical about it. But do you have any thoughts or guidance regarding grapefruit or grapefruit juice? And I'm not talking of grapes, but grapefruit and the potential impact it may have on medication or its efficacy. Thank you.
So just to make sure that I understand the question, so if we're administering Penthrox and somebody has had grapefruit juice, because yes, you're right, grapefruit juice interferes with other medications. Would it interfere with Penthrox, and could it potentially cause harm? So there haven't been any studies because it is metabolized both in the liver and in the kidneys. There haven't been any studies showing that it causes harm. So the short answer is no. The bigger answer, the longer answer is we will monitor it, and we continue to monitor it in terms of one, because as we initiate these studies, what we're looking at is we're looking at organ injury, and when we already have areas of known organ injury, which is liver and kidneys, we're going to be looking at liver and kidney functions, and that's how we're going to be doing our follow-ups as well. So great question. More to come as we get more information about it. Yeah.
Thank you. Question here, then go over there.
Hi, thanks for the great presentation. My name is Philomena Mazzella. I am a nurse practitioner at the Toronto General Hospital, and kind of to follow up on the discussion around types of pain. So I apologize, I missed the first couple of slides coming in, but I was wondering, with the Penthrox in the emergency department, are there particular sickle cell patients that you guys are targeting right now? Like, often we have a small percentage of patients who, unfortunately, over time, you know, they're on high MEQs of opioids. They've developed hyperalgesia, tolerance, you know, diagnosed with nociplastic pain. So I'm not sure if what your experience is, and sometimes we don't know what we're treating anymore. Like, you know,
Yep.
Are they having vaso-occlusive episode or, you know, an exacerbation of their underlying chronic pain? So it's kind of exciting. I'm wondering your experience in that too. Sorry, a second question. I'm also wondering, I was super excited to see that it's used for things like IUD placement. Mm-hmm. Oftentimes our patients will go for procedures like port change and that, and they're given very cute doses of opioids compared to what they normally take, and it's not going to touch it. And I was just wondering, you know, if it's a medication that we as outpatient providers can sort of prescribe to them, kind of the way we prescribe Ativan for, you know, an MRI. Can we, hey, you're going for IUD placement or port change, you know, here's a prescription for Penthrox. I don't know if that's a possibility. Yeah.
So. Yeah, no, very good questions. And so starting with your first question, so answering that first question, so our thought had been to have methoxyflurane available to every patient coming to the emergency department in sickle cell crisis. And often these are people whom have been to Humber in the past, so we know that there's a history of it, but of course there are going to be cases where, you know, that isn't the case. As well, newcomers. But on the most part, we know they're in crisis, and we will hand them the pipette, ideally. So this is sort of like the research model that we're looking at. And, you know, here's your pipette, and then while we're getting them all set up for their IVs or whatever that they're going to be getting for the longer-term pain relief and the treatment of the crisis itself, they have pain relief available. The benefit of methoxyflurane is that patients who have had a history of sickle cell disease, who often will have a high tolerance level, methoxyflurane works in other ways. So whether they have a high tolerance to opiates or not, it won't affect how much methoxyflurane they're going to need, so they can actually self-dose and help manage their pain or co-manage their pain. And it's nice because some healthcare providers feel uncomfortable giving those massive doses of opioids, and so patients are undertreated. And now you can have a co-analgesic sort of a relationship between the methoxyflurane and the regular analgesia. So it's all looking very positive. But the specific answer to which sickle cell patients will receive it, because yes, you're right, some of them have chronic pain as well, and you're not sure, is it sickle crisis or are they just in chronic pain, or maybe a bit of a blend. We can give them to all. As far as outpatient use, yes, so at Sunnybrook, which is where the oncology department is using it, they receive a prescription for methoxyflurane before they go to get their bone marrow or whatever it is that they're getting done. They go pick it up at the pharmacy, they bring it with them to the ambulatory clinic, and it is used in an outpatient setting in that case. And then the providers are trained on how to administer it, and then they administer the methoxyflurane that the patients have bought for themselves. And that's what we've been doing in the pain clinic as well. They receive a prescription. The cost is, it depends on the provider. The cost of the actual drug itself is about $50, and so depending on the provider, the pharmacy likes to, obviously they need to cover their own expenses, so the cost to the patient can be between $70 and $80, and that's what they get on their prescription, and a lot of it is covered. It wasn't initially, but a lot of it is covered under patients' health plans.
Do we have time for one more? Or we can do two more, sure.
Just a quick question. I was wondering, with the Panthrax and your analysis with the studies in New Zealand and in Australia, you mentioned that there were age restrictions in terms of its indication, who they're using it for. And so my question was with regards to what those limits were in Australia and New Zealand, and what your research had you looking at its use in Canada. And in addition to that, if there was, I guess it's still being developed, but what some of the long-term indications or long-term usage factors were for people who were maybe using this over years.
Yeah. So in Canada right now, it's only approved for people 18 and over. In other parts of the world, it's approved for patients who are 12 and over. And when we look at how kids respond to methoxyflurane, like children who respond to methoxyflurane who receive it, there hasn't been any harm. So the push is to actually make it available to kids as well, under the age of 12, who can follow direction on how to use it, because we believe that it can provide significant pain relief. So it's going in that general direction, and I believe that Canada will follow the rest of the world with respect to the administration. First for kids 12 and under, and then beyond that. Now, to the other part of your question in terms of harm, there hasn't been. In fact, one might actually argue that children who physiologically are healthy and don't have other comorbidities, of course, except for sickle cell, which is in itself a serious one, should respond to it quite well, and it shouldn't cause any harm.
Great questions. Okay, we'll end with the last question here.
Thank you. Thank you for the presentation. I am not a healthcare worker, I work in finance, so apologies if this was already addressed. I just want to know, like, we talk about opioids, we talk about fentanyl, like, is this addictive? Could it become addictive? And could it be abused?
Could Penthrox become addictive? Yeah. So the short answer is no. The studies have shown that it has not created an addictive potential. And part of that could also be because it's hard to get. You can't really get it by prescription. You can't get it on the street. So I'm sure that if we were to have it out there, we might see it different. Out there meaning accessible to the everyday person, then maybe that would change. But all of the studies that we have worldwide report demonstrate that there's no addictive potential with methoxyflurane right now.
Okay, thank you everyone for the questions. So thank you, Dr. Rivlin, and thank you, Sickle, for a successful fifth conference. I'll hand it over to Delaney. Thank you.
Thank you. Please, folks, can you join me in a round of applause for Dr. Rivlin and Dr. Arak?